those I will show in couple of slides. Very important, I said earlier, your CT protocol should be established so that you can identify the anatomy. So the next important aspect of contouring is that you need to understand certain anatomy, which is very important for contouring. And in the slide here, I am showing some anatomical landmarks. And on the right side, if you see, do you have a pointer? Pointer, please. So on the right side is an axial slice of an MRI T2 weighted. And what is shown is the attachment of lateral ligaments or the parametrial tissue. Can you appreciate that on either side? So that's the cervix, and on either side is the parametrial tissue, and in dotted lines is the boundary of parametrial tissue which is shown. So this is very nicely seen on MRI. That is why I have taken an example of MRI image here. The same, if you see on coronal section, that's the uterus, and if you see the parametrial tissue which are seen from the paracervical region going laterally, and if you see carefully, now this is not working, it's tired. Okay, I'll use the pointer here, yeah. Okay, so if you see laterally, these are the attachments of parametrial tissue, but you see there is a fatty tissue which is more or less homogeneously white. So that is the fatty tissue which harbors the lymph nodes and vessels. So the attachment of parametrium is here, medial few millimeters medial from this muscle which you see here. Okay, this is very important because you need to identify the parametrial tissue for your contouring, right, on CT. So this information is very vital, and you can understand this anatomy better on MRI. Same is shown on axial here and on sagittal. The sagittal section here, this is again very important because this is a section which shows uterus-cervical junction, or something called as isthmus. So isthmus is a good landmark for defining the cervix superiorly. Okay, it is called isthmus or uterocervical junction. Okay, so if you see carefully on MRI or CT, that is the thinnest, narrowest part. Uterus is enlarged, cervix is elongated, and this is the narrowest part. So junction is narrow. Yes. So now you see, I've shown this on CT now. On this side you can see uterine artery, and I didn't show the uterine artery on this side. Okay. On coronal section, please understand this correctly. On coronal section, you will see in the area of parametrial tissue here, oh come on, this is not working. On the area of parametrial tissue here, you will always see uterine artery crossing to the midline. So that is the upper extent of parametrial tissue in superior inferior region, and that you can see very well on this CT scan here. Can you see here on the right side? That is the uterine artery which is coming from lateral going into the uterocervical junction medially. On right side it is here, on the left side you can see here coiling here. And if you see that level on coronal section, that is invariably at the level of point A. So point A is nothing but uterine artery and ureter's crossing, right? So that is why we always look at uterine artery. And why do I want to see uterine artery? Because it's the upper extent of parametrial tissue, number one. Number two, point A will be in that region. And that is why we always recommend that you push in a contrast for your planning CT. If you push in a contrast, then you can see the uterine artery very nicely here. This is another example. Can you see here uterine artery nicely crossing here on the right side? Can you appreciate that? And in front of that, there is a white dot. Can you see that white dot? That is ureter. Ureter. Okay. So this is exactly where it is crossing. That's the point A. Is that clear? So these anatomical landmarks are important when you are contouring the parametrial tissue, especially when there is induration or disease. So this is another example here with IV contrast. You see uterine artery nicely seen crossing the midline here on this side, and then something here, and that is seen better on the next slide here. These are the 3 axial slices. I have shown an example at the level of ring, 1 centimeter above the ring and 2 centimeters above the ring. Why did I do that? In my previous lecture I told you, pear-shaped distribution. Point A, 1 centimeter below, 2 centimeter below. So you see the anatomy. It correlates. So at 2 centimeters more or less you are seeing the uterine artery. So it anatomically, your parametrial tissue is between these 3 slices only. Okay. So target concept, I mentioned that it is more or less similar to what we have done in MRI. And on CT, we usually contour high risk CTV only, because on CT we cannot see a GTV. We cannot identify gross disease on CT. So it is very dangerous to draw a GTV residual at the time of brachytherapy on CT. But you can draw a high risk CTV, because high risk CTV is nothing but cervix and parametrial tissue if there is some residual disease or minimal residual thing. So that is why in our recommendations, if you see, we have said that we can only contour high risk CTV and give some margins to make it intermediate risk CTV. Okay. These are all repeat. Yeah. So these examples I wanted to show. So this is an example of first one, left para. Please concentrate on left para. On the left panel is MRI. Left para is obviously almost up to lateral pelvic wall here. And at the time of brachytherapy, you see I have contoured something here. On ultrasound, those values, and on CT, those values adopted and contoured as a high risk CTV. So if you see MR versus CT, it is more or less similar, right? So like that you can do it for many situations. Let's talk about today's case. So please load HBCH 01 CT. Okay. So before contouring, it's very important that you review the case again. Clinical drawings at diagnosis, imaging at diagnosis, whether it is CT or MR, find out where the disease was, and then clinical examination findings at the time of brachytherapy. And then evaluate that case and then contour it. Okay. So this patient has a large tumor at cervix, both endophytic and exophytic growth. Both paras are involved, left para more than right. And here, as I mentioned in my previous talk, now we define NMDs, near maximum distance on left is 3.5. So obviously the left para is more involved, and right para is 2.5. So the total width is 6 centimeters. And thickness is roughly 3 and height is 3. Stage is T2B or 2B. No nodes on CT or MR. These are the images at diagnosis, MRI at diagnosis. You can see very well, more or less correlating with what I have drawn here. Right, left para is involved more, right para is less. On coronal section, you can appreciate that left para is more, right para is less. If parametrium is involved, you will not see the rim. On T2 weighted image, you will always see a black rim, stromal ring. If that is disrupted, parametrum is involved in the brachytherapy. This is a coronal sagittal section. Here on T2 weighted image, you can appreciate large tumor, which is high signal or isosignal intensity. But what you see at the top, the dark, oh come on, this is again. So can you appreciate this part, dark part here? So that is nothing but normal cervix. So it means the remaining part of cervix is replaced by this tumor here. Okay, but at the top, wherever it is at the junction of cervix and uterus, the normal cervix is not involved. So there is a rim of normal cervical tissue at the level of isthmus. So what it means is it is not going into the uterus, right? So go back to my clinical drawing. If it is not going there, then you can always measure this height from the fundus and keep your high risk CTV at that level, right? So that is the advantage of MRI diagnosis. If you are able to get that, then you can contour it efficiently. But if you don't have, then you have to include up to here. Okay? So this patient received chemo and radiation, external beam, and these are the clinical drawings at the time of brachy. Very good response. Right para is more or less complete. Left para, still some disease in the left para as part of indurations. And now you see NMDs. Right was 2.5, now it has become 1.5. Left was 3.5, now it has become 2.5. So the total width is roughly around 4 centimeters. So we did a advanced brachy application. The top panel is MRI diagnosis with clinical drawing. The lower panel is after doing a CT protocol with the applicator in place. The image is sagittal, axial and coronal. So now if I have to draw a CTV for this patient, so let's say at this, in the lower part, I would draw from here. Do you agree? From here, so I can see something here, I can see something here, I go down. Maybe I'm not very efficient because this pointer is a bit. So this would be my contour, let's say example. Okay, so let's say you draw this, go back and measure what is the NMD from this side to this side, this side to this side. If it is matching to what clinically you have done, then you are perfectly all right. Second additional information, if you have done a transrectal ultrasound, again those measurements you adopt that. You will invariably do a nice high risk CTV on CT. Is that clear? Okay. So this is the case which you are going to contour now. Okay. So again at the level of ring, 1 centimeter above the ring, 2 centimeters. So start contouring high risk CTV, and please look at these slices here. I have written contouring on these slices, and I have put this sequence because when you start contouring, always start contouring from a slice where everything is clear to you. Okay, go down and go up. Okay, so go from area where everything is clear about the contour, above, below. And that is why I have given these slices. So where to see the slices, I will just show you now. So if you see on the top here, can you see? Slice fraction 1. Can you see here the pointer? In the left upper corner, first line, that's slice number 1, slice fraction 1, because below that another slice at is written. So don't look at slice at, but look at slice fraction. Okay, and then go to 19, contour, go to 17, contour, go to 15. So you have to only contour 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, around 10 to 12 slices. That will be our high risk CTV. So if you can contour in next 10 to 12 minutes, less than a minute for each slice. Okay, contour, and then we'll see what your contours look like. Is that clear? Only high risk CTV on CT. Okay. And since there are less laptops, let there be a consensus contour. 3-4 of you together can sit and do a contour. 3-4 of you together. Each table may be one laptop.
Do they know how to control?
Yeah, I think so. They did lung, no? Or you can tell them. Yeah.
Well, ask how many people have control on education.
So please raise your hands. How many of you are well versed with contouring on Educase? Everybody is well versed? Show it in a couple of minutes, Mika.
So quickly, if you haven't, you need to use choose your structure from the left and right corner, top left corner. Then you can choose your either freehand by click and drag, or then you can use point to point, which will add just points, or then you can use the brush contouring. You can use the brush size from here. Was there anything else, really? Yeah, and then if you want to erase, there's an erase button that will erase your last things.
So show them where to select.
Yeah, so high risk CTV over here. On a drop down list, you use high risk CTV. So 19 would be, oh yeah, sorry.
But I think 19 here is not 19 like you. Because here, this is 19. They don't have, actually, there is no difference. So it's completely different. So what is right?
What size are you looking at?
Size have changed.
No, they haven't.
Maybe this is I've loaded Lisbon.
So that's what 19 looks like?
Yeah. Yeah, lost. So start from this slice. Can you see this slice? 54. Yeah, 54, 55, up and down. Yeah. Yeah, I need internet. Which one? This one? No internet. It says no internet. What's that? Yeah, it's it's very slow. Yeah, 57. Let them contour few slices. It's loaded already?
Yes.
Yeah, maybe. This one? And then this.
You're completely logged out.
It's logged out?
Yeah, well, you're logged out. Log in back in.
Oh, come on.
Ooh, you're so good.
That was last time. Yes.